everyone, our project is on prediction modeling for coronavirus cases using state public health policies. Over 500,000 people in the US have died from coronavirus, and had state governments acted faster in creating policies to combat the pandemic, over 36,000 lives could have been saved in the US. The problem we are trying to solve is what kinds of public health policies should states adapt in order to minimize the number of cases during a pandemic? Questions we will take into consideration are: which policies had the greatest impact on lowering state infection rates? Did the political affiliation of state leadership in 2020 influence the infection rates per state? And what are the steps states can take to lessen the burden of the next pandemic?
Let's go over our data methodology. We collected data on state COVID policies from September to December 2020, and we chose this timeframe because COVID had proliferated through most states, and states had also developed policies targeting it. We aggregate data from Oxford, Kaiser Family Foundation, and CDC into a single data set, and we also performed data processing. For each policy, they had a level from 1 being a recommendation to 3 and 4, which would be a higher level restriction. And so one hot encoding helps split that up into different binary variables. We did normalization on numerical variables, removed outliers, and did feature engineering. And one example of that is using a ratio of new COVID cases over density as our Y variable. The first model we did was linear regression with an R squared of 83% and a OSR squared of 5.9%. We also performed VIF and removed any variables with high p-values. In the middle, you'll notice that these are the variables with the highest reduction in the new COVID cases ratio.
Our second model is random forest regressors. We set our N estimators to be 500 and the max number of features to be 35. You can see from the table on the right, some of the most important features are populations and contact tracings. The out-of-sample R-squared for this model is about 64%. The next model that we did is the decision tree regressors with k-fold cross validations. We set k to be 5. After training with the best parameters, our best accuracy is about 89%. Some of the most important features for this model are income support and contact tracings. The out-of-sample R-squared for this model is about 63%.
Our most uninformative model was the lasso model. Our training R-squared showed some promise at 84%, but the out of sample R-squared is 1%, which is which means it did not perform well.
Our fifth model was the blending model. We blended a random forest model and a linear regression model, and then predicted our dependent variable based on the meta features that were produced by these two base models. As a result, our training R-squared was 0.89 and our out of sample R-squared was 0.63. In terms of analysis, our best models performed at around 63% OSR squared. And the reasons for this only moderate OSR squared performance was potentially due to omitted variable bias due to potentially two sources. One being that we split the training and test data on the month, so there might be some time-dependent variables that we didn't account for. And in addition, we also did not control for certain variables as it regards to the differences in the states. So for example, just randomly, maybe temperature could be a variable that we might have wanted to account for. For the next step, we'll go on to bootstrap the difference between the OSR squares of the two high-performing models, and then go on to assess whether the difference between the models is actually statistically significant or not.
Moving forward, we want to assess the impact on both federal and state level to provide data-driven recommendations for those policymakers, as well as lower infection rates and deaths in future pandemics in those states. We also want to develop public health state plans that will better prepare states for combating future pandemics.
So lastly, for future conditions of expanding the scope of our project, first we want to expand the time frame. Currently we have September to December 2020, but for using data from earlier from September would help us to see the impact of the policies before and after policies were implemented. And expanding beyond December would help us to see the long-term impacts of policies. And then we can also add more variables, so including additional variables like the number of ventilators in nursing homes per state by scraping COVID policies from online will help to decrease omitted variable bias. And lastly, we can also include more countries, and different countries has had different COVID policies. So seeing which policy worked and which policy didn't can help us to use that data to solve different public health issues in the future.